I'm Duarte. I'm a brain and spine surgeon. I have been in practice for 23 years and I have performed more than 17,000 surgeries. As you can imagine, over 23 years, there have been a lot of changes in the way we perform spinal surgery. Initially, when we did spinal fusions, we were just laying bone on the lateral aspect of the spine, what's called a posterior lateral fusion. The fusion rates were in that grade and the outcomes were in that grade. We then started to augment that by using pedicle screws that attach to the vertebral bodies to provide more stability. And that improved the results some. Then eventually, we decided to go with inner body fusions. The first kind of fusions that were performed were either posterior inner body fusions or anterior lumbar inner body fusions. And we had pretty good results with that. One of the challenges we've had through all these operations were, number one, how do we obtain a solid fusion between the vertebral bodies? And number two, how do we correct the deformity of the spine? Either the spine is too flat or it's curved in the wrong direction. And so we had multiple procedures. We had BAK cages, we had XLIF procedures, all different procedures in order to obtain a solid fusion and to try to correct the curvature in your spine. I've started to adopt a new procedure called an OLIF approach to the lumbar spine or anterior lateral approach to the lumbar spine. It's kind of a hybrid procedure. It's a mixture between a lateral lumbar fusion and anterior lumbar inner body fusion. So we're using the space in between an anterior inner body fusion and a lateral inner body fusion. So we approach the spine from an oblique or an anterior lateral approach. This has a lot of advantages. Compared to a lateral inner body fusion, we are not going through the muscle. We're going anterior to the psoas muscle. So this approach is also called an antipsoas approach. That is an approach anterior to the psoas muscle. By doing that, what we have found is, number one, you have less postoperative pain. A lot of patients that have lateral lumbar fusions develop pain in the thigh that may take weeks or even months to resolve. Number two, because we're not going through the muscle, we put the nerves, the lumbosacral plexus that transverses the psoas muscle, at less risk. So you have a lesser chance of developing neurological complications from this procedure. Compared to an anterior lumbar inner body fusion, because we're going lateral either to the artery if you go through a left-sided approach or a vein through a right-sided approach, you have much less likelihood of having a vascular injury. One of the biggest issues with an anterior inner body fusion is injury to the vessels, typically the vein, which can cause sometimes catastrophic bleeding. The advantages of the anterior approaches to the lumbar spine or the lateral approaches is that we can use spacers or cages that have more lordosis, more curvature. We have understood in the last few years that preservation of the curvature of your spine is critical in terms of obtaining good postoperative pain results. So when we go from an anterior lateral approach, we can use spacers that have 15 or 20 degree or even more degrees of lordosis on the spine. My preferred implant when I perform inner body fusions from an anterior lateral approach to the lumbar spine is a titanium cage made by Camber spine. It's called a Spira cage. The reason I like the Spira cage is, number one, it has different degrees of lordosis, 15 or 20 degrees. And I think for most of my patients, that provides me enough lordosis, enough curvature to correct some degree of what we call sagittal imbalance, and also to prevent flattening of the spine when the spine gets fused. Number two, it has a surface that has been specifically designed to maximize, number one, friction between the vertebral bodies. So by preventing micro movement between the vertebral bodies, I think that facilitates fusion. It also has a roughened surface that has been designed to facilitate the ingrowth of bone. So you have an earlier fixation of the case of the vertebral bodies, which again, I think facilitates the inner body fusion process. The final thing that I like about the Camber cage is that it's made of titanium. Now, a lot of the titanium cages are very dense. It's very hard to see whether there's bone growing in and through the cage. In this cage, as you can see, has a very open architecture. And so it allows the bone to grow through all these little holes. And when you look at it and profile in an x-ray, you'll be able to see the bone growing through and through the cage, which is very important to assess whether a patient's having a solid fusion. One of the things that I really like about the OLIF approach, or the anterior lateral approach of the lumbar spine, is that it's a very flexible approach. So the procedure can be performed either left side up or right side up. The L5S1 level, in my opinion, is better approached right side up. Coming from the left-hand side, you're doing your approach this way laterally. You're going to find the artery. You have to stick in front of the artery, find the vein, go in front of the vein, and then retract it this way. Here, you're coming this way, you're just going straight down. So the vessels, typically in most patients, the iliac vessels, the right one is more to the right. The left one, when it starts, is going to be more midline, and this is what causes most of the vessel injury when you're doing anterior lumbar fusion. So when you approach the level right side up, you rarely have to manipulate those vessels at all. It provides a very clean corridor, a very clean access to the L5S1 level, and this allows this procedure to be performed by the spine surgeon by themselves if that's what they want, or of course you can always have the option of having an access surgeon help you with the exposure.